one because it's probably one of the most common.
Rapid response, 3316, all clear.
So it's probably one of the most common diagnoses that we're gonna see. It can be one of the easiest ones that we treat here in the ICU, but it can also become one of the most complicated diagnoses that we treat. So what's actually going on in DKA? Why is it so important? How do you even get into DKA? It starts because there's lack of insulin from the pancreas. So this is primarily gonna be your type 1, right? There's no insulin production, right? They're also not taking their insulin at home, right? Or something is stressing them out. So no insulin, no glucose is able to go into the cells, so therefore the blood glucose level just continues to climb. So what happens is the liver, it mistakes this because it doesn't see insulin, so it just continues to build up that glucose level, all right? So you have higher glucose. Well, the blood glucose cannot be utilized in the cell. There's no energy for them to use, so it's gonna now try to break down any type of fatty acids that it can get, any type of fat, and that fat breakdown, the byproduct, gives you all these ketones. High ketones, that's your acid. So now you've got high blood glucose levels and you have high acid, these ketones that are forming. So then what happens is the kidneys, they start going overloaded. They've got high glucose levels, they have high ketones, they're gonna try to get rid of all of it. So there goes all of that with all of your fluid. So now you've got this severe dehydration that's coming along. So you got elevated blood glucose, you got high ketones, you have severe electrolyte abnormalities with severe dehydration, and that gives you the diagnosis of DKA. So when we admit these patients, we're looking for 3 criteria. How do you even diagnose it? Well, we talked about the blood glucose. What does it have to be? By definition, somewhere greater than 250. Do we see it much higher? Yeah, 5, 6, 700. Metabolic acidosis. This is that ion gap that has to be present, right? So the ion gap's high, greater than 12. We usually see it greater than 30, right? It doesn't even register. The bicarb's non-existent, less than 5. It doesn't even come across to us. And then positive ketones. So how do we even check for ketones? There's 2 different ways we usually do it here in the hospital. Urine, ketone production, and it's a lab value, beta hydroxybutyrate, right? That is an acid, right? So we check for those. If that beta is greater than 3, that's pretty much an indicative that we've got ketone, or if we see +2 ketones in the urine. So if I see those 3 things, then by definition the patient's in DKA. But why do they even come to the ICU? Why can't they go to step down? So we use a pH cutoff of about the 715. Okay, so usually pH of 715 or less, they're probably pretty sick. They probably need ICU level of care. Now I use this as, if somebody comes in and their pH is 718 and ED calls me, the first question I say is, are they doing Kuzma breathing and how do they look, right? Because if they're super, like they've never done DKA, they've never been in DKA before, they're super lethargic, they're super out of it, and their pH is 718, I'm probably gonna be more amped to bring them here because they're probably gonna need a lot more care from us. If it's some of these revolving door ones that we see over and over again, then maybe the 718, 720 can go to this ICU. So what do they look like on physical exam? So I talked about their breathing. What's Kuzma breathing? What does it mean?
Respiratory compensation.
Okay, but they're doing what with the respiratory? Are they breathing shallow or are they breathing big?
Shallow.
No, they're breathing big. This is big breaths and a lot of it. So if you watch their chest, they're doing it. And the reason why is they want to get rid of as much CO2 as they can. Because if they can get rid of CO2, then they can neutralize their pH a little bit better. And so this is where you see the CO2 drop down to below 20, right? It's crazy low. But they're doing Kuzma breathing. So this is a compensation mechanism, right? It gives you that acetone breath, that's that fruity breath we see. They're dry mucous membranes. Like I said, they have this osmotic diuresine. They're just pouring out fluid, right? So they're super dehydrated. But because they're dehydrated, their heart rate's high, as we would expect. But they're altered. They're lethargic, right? They look like crap. They're hard to even wake up in the bed. So why do I not intubate them? Why don't I intubate them for airway protection? Perfect. I can never meet this respiratory compensation. They are pulling liters and liters and liters, something I can never do with a ventilator. I'm gonna struggle to meet this demand on a ventilator. The only time I'm ever even gonna consider intubating them, if 1, they're not doing this, they're not even breathing adequately, they're so altered or they're aspirating or whatnot. If they're not doing Kuzma breathing and their CO2 is climbing because they have no compensatory mechanism, then maybe I do intubate them. But they're the least favorite of any patients. If we ever tell you you have a DK that's intubated, high alert, because they're gonna be very unstable. Their pH is gonna continue to drop as I'm trying to make them better. So who goes in to DKA? We call it the 5 I's. The biggest one is ignorance. So what do you think that is? They just don't. That's your type 1 diabetic. That's the person that just turned 18 and they no longer over the care of their mom and dad, and they no longer need to take their insulin. You know, they know better. And they come in. We have the same ones, right? That come in and come in and come in. So ignorance is probably going to be the first one. This is the one that A1C is greater than 14, right? But what do we need to make sure we're not missing? Which are these other 4. And so I always tell everybody, these are the 4 that's going to get you in trouble if you miss them. Infection, stress response to the body, right? Any type of infection. Ischemia. So ischemia can be somebody comes in really bad peripheral vascular disease, or they have a clot in their leg, or an arterial PAD. That ischemia is going to cause a stress response that can lead to high glucose, leading to high DKA. Intoxication, this is your alcoholics. This is your drug overdoses, potentially can send themselves into it. Infarction, it's known as a silent MI. It's the one that comes in that doesn't have chest pain, then you get the EKG and they've got a STEMI. So, very rarely, I've seen 2 of these in the last probably 12 years, but they can happen, and they come in as silent MIs, they don't even complain of an MI. And it's the MI that sent them into DKA to begin with. So, what we do is we assess them for criteria. We see this, I'm okay with this, okay? We're always okay with this. Come and get me if they're not doing Kuznal breathing. Watch their chest, and you'll see it. You'll see them take these deep breaths, but they'll be so lethargic, but they're breathing really fast and really high. It's one of the easiest things to treat. It seems so simple, y'all, right? Isotonic fluids, primarily lactic. You're gonna see us, we love LR. And why do I love LR? Because normal saline has chloride. And when you have a high chloride, you cause your bicarb to go low, okay? It's called a NAGMA, so it causes a metabolic acidosis. So if I give 4 liters of sodium chloride, my chloride's now gonna go to 130. I'm gonna fix my DKA, because I'm gonna do all this great stuff, and then they're still gonna look like crap. Their bicarb's still gonna be awful. Their ion gap's gonna close. And you're gonna tell me, why do they still look bad? Why are they not eating and drinking? And it's because in the ER, we're resuscitating with nothing but normal saline. So we're gonna resuscitate them with lactated drinkers, has less chloride, and it's not gonna create that worsening metabolic acidosis. And we're talking lots of fluids. I give at 4 liters baseline on everyone, 4 liters, for the most part. During COVID may have been a little bit different, but for the most part, we're giving them lots of fluid because they're losing it from here. Insulin, as soon as they can give insulin, they should give 10 of IV insulin pushed in the ED. Y'all don't usually see that part of it before they start the insulin drip. The hope is that if they can start that, they can start stopping the ketosis from happening, stop the acid production from forming. And then electrolyte replacement, super big, because as you start giving insulin, you start shifting everything in and out of the cells. And that is probably where I've seen the most critical of these patients decline really quickly. And it's because we do all these things, we're doing a great job, we're giving the fluids, we're giving the insulin, we're doing all these things. But if we're not keeping an eye on those serial labs, this is where I've ran into trouble. What happens if your potassium when you give insulin? Yeah. So that potassium that came in at 6, at 5.8, because they were severely acidotic, not only are you fixing the acidosis, right, but you're also pushing potassium, you're driving it back into the cell. And so the serum potassium is going to continue to drop. If it's less than 3, your knee-jerk reaction should be what? Stop it. Stop it. We'll never fault you for stopping the insulin drip and telling us you're stopping it. And then rapidly replacing it. What's the best way to get potassium? Don't cheat. Why? Yeah. So it's going to absorb tenfold if you give it by the gut. The question is do you give it by the gut? In some patients that are actively vomiting with DKA, no. I mean, you're not going to get anything. But the ones that come in here all the time that you know can take PO, if I can get them to take PO, I'm probably going to give them PO potassium. Because the quicker I can get this insulin drip going, what am I stopping? Yeah, if I stop the insulin drip because the potassium's low, what happens again? Ketones start to form. Yeah, so it's just this revolving door. The longer we keep them off of the insulin drip, the longer we have for this DKA process to open back up, the ion gap opens back up, and we start this whole cycle all over again. Why is potassium so important? What's it going to cause if we don't treat it? What happens to potassium of 1.6 on a patient? Yeah. Yeah. So I have been a part of a code from a patient that was held in the ED that had a 1.6 potassium. So near and dear to my heart on the potassium and not wanting to see that happen to anybody. So stop the insulin drip, notify it, let us know. But really important, serial labs, take them, get them. If you can't get them, let me know. I'll be more than happy to get them. Like, I have jumped in on many people on night shift that can't get their labs because they're so dehydrated, they're so going down. Let us know, because asking lab to come get them if they can't come right away, this is super critical for us. So just, or let us know that you can't get them so that we know that somebody else is working on them. Because we're a team and I don't want y'all to feel like we can't get those labs. This has mainly been an issue in the ER. So just following up on serial labs is really important. And then changing your fluids, right? Because if you don't change your fluids in time, do we put the patient on insulin because of high blood glucose levels? Is that why they're on insulin? It's a tricky question. So do I put them on insulin drip just because they have a high glucose level? No, because what happens if their ion gap on repeat labs is 20 and their blood sugar is 90? Do you turn off your insulin drip?
No.
No, why? Are they still in DKA?
Yes.
Yes. So insulin, great, yes, it will bring the sugar down, but what I'm using it for is to close my ion gap. It's to stop the ketosis, right? Give them what they're missing. But if the ion gap is still elevated and your blood sugar's normalized, or they even get low, you have to let us know, because we might even change your fluids from D5 half normal to, at times, how many of them have y'all seen us
D10.
then put them on D10, right? Because it's not the sugar I'm treating, it's the DKA, right? So it's fairly important. Don't just stop your insulin drip just because their sugar goes to 80. Let me know, and then we change their fluids appropriately. Now, granted, if their ion gap comes back and is 10, then you're like, well, Hannah, my gap is closed. What are we doing? And then those are the appropriate cases to consider transitioning them off of the insulin drip. Questions?
Great job.
Thank you.
It's really, truly, to me, it's one of the neatest diagnoses, because if you look at their initial labs, it's red. Like, it's literally, if there is not a critical value, it is straight down the board. They look like they should be dead, right? Their pH is 6.9. How many patients are alive at 6.9? You and I aren't, right? So it's just really interesting diagnosis that if you do two simple things, right, and correct their electrolytes, you can take them from a 6.9 to a normal pH within 12 hours. So,
Hannah, when do you want us to turn the insulin drip off when we swap to sub-Q insulin?
yeah. So, you will switch them from an insulin drip to sub-Q when the ion gap closes, and ideally they can take PO. That's really kind of the kicker. So if you have patients that are on the vent, sometimes we'll switch them over to 2 feet and then transition them off. If we have a patient that's, like I said, this has been the kicker, right? So sometimes their ion gap's closed, they're still very acidotic from anagma, high chloride. Those patients might be a little bit harder. We have to keep them on insulin drip, we will. But the goal will be to transition them once the ion gap has closed, and ideally they can take PO. And then of course you're putting them on a diabetic diet, you're giving them long acting, then shooting the insulin drip 2 hours off, then slow them on starting scale. Now, if they occasionally, you're in the ICU, right? If an infection is causing it, we haven't fixed the infection, then is there a likelihood that their DKA could open back up? Yeah. If we admit them and we put them on stress dose steroids and we get them through the whole process, is there a process that we kick them back into DKA? Yeah. Same thing. So any of these reasons, like, we could potentially send, and you'll see that. You'll see some say something, oh crap, well, your gap just opened up, we gotta go back, right? We do not have endocrine here. Endocrine in Atlanta runs things a little bit different. They will actually order a beta hydroxy every day, and they will not transition you into a beta hydroxy. It's completely normal in less than 1. So that's a little bit different. We don't quite do that here. Some studies have shown you can actually start feeding them earlier. So that's also been introduced as well.